Good morning, everyone, and welcome to today's webinar, Modeling Health, How Health Systems Can Take Action to Reduce Sugary Drinks. My name is Kristen Sullivan, and I'm the Director of Nutrition and Physical Activity at the American Cancer Society, based in Atlanta. This webinar is the first of a four-part series sponsored by the American Cancer Society and the Public Health Law Center on creating healthier food and beverage environments in hospitals and healthcare settings, with a specific focus on reducing sugary drinks. Sugary drinks are the largest single source of added sugars in our diet and contribute to chronic diseases such as type 2 diabetes, hypertension, heart obesity, which in turn increases the risk of certain types of cancer. Sugar drinks are also a health equity issue. Black, Indigenous, and people of color are targeted by beverage industry marketing and disproportionately experience nutrition-related chronic diseases. These inequities are even more pressing in the era of COVID-19, as we see the virus taking a disproportionate toll on populations with a high burden of chronic disease. We have two outstanding presenters today who will discuss the connections between COVID-19 and diet-related chronic diseases and the unique role that health systems play in supporting healthy eating through policy and environmental change. Our first presenter, Dr. Darius Mozaffarian, is a cardiologist, Jean Mayer professor, and dean at the Tufts Friedman School of Nutrition Science and Policy, as well as a professor of medicine at Tufts Medical School. Dr. Mozaffarian has authored more than 400 scientific publications on obesity, diabetes, and cardiovascular disease, and on evidence-based policy approaches to reduce these burdens in the US and globally. He has served on numerous roles, including for the US and Canadian governments, American Heart Association, World Health Organization, and United Nations. His work has been featured in a wide array of media outlets, including the New York Times, Washington Post, National Public Radio, and Time Magazine. In 2016, Thomson Reuters named him as one of the most influential scientific minds. Dr. Mozaffarian will discuss what is currently known about the connection between COVID-19 and diet-related chronic diseases. Our second presenter today will be Julie Ralston Aoki. Julie is the Director of Healthy Eating and Active Living at the Public Health Law Center, which supports tribal, state, and local communities in developing and writing laws and policies to support healthy food systems and active living in ways that advance health equity. She has worked with hospitals and state hospital associations in the Midwest and the country in supporting policy work to promote healthy food environments and worksite wellness. She's the past president and current member of the Minnesota Community Health Worker Alliance Board, a volunteer member of the Robbinsdale Human Rights Commission, and the parent of 3 children. Before joining the center, Julie served as an assistant attorney general with the Minnesota Attorney General's office. And today, Julie is going to be talking about how health systems can support healthy eating through policy and environmental changes. So we're really excited to have these great speakers today, and I will turn it over to Dr. Mozaffarian to get us started. Dari?
Thank you so much to the Public Health Law Center and to the American Cancer Society. I just my microphone, I hope people can still hear me okay. So I'm going to share my screen. And I'm going to be speaking today about nutrition, chronic diseases, and COVID, and how these things are interlinked. So I think it's pretty clear, and there's growing recognition just this week, multiple articles and editorials on the links between food, nutrition, and COVID-19, both for immunity and a healthy immune response, the tremendous tolls on food insecurity, the comorbid risks, which are driving hospitalizations and deaths, the impacts on seniors who often have hidden hunger and subclinical nutrient deficiencies, major implications for disparities by color, by income, by education, tremendous challenges to supply chains, jobs, confusion for the public, and more. And this is, I think, one of the increasingly recognized facts that COVID is particularly bad because we are a really sick population. More Americans are sick than are healthy. Half of all adults in the United States have diabetes or prediabetes. We should just end the talk there for action, right? Half of adults have diabetes or prediabetes. More than half have some form of cardiovascular disease. Cancer, of course, is an equally leading cause of death. 3 in 4 adults are overweight or obese. And this, widespread sickness has tremendous economic costs. In the last 50 years, healthcare costs have skyrocketed from about 5% of state and federal budgets to almost 30%, and inflation adjusted from about $80 billion in costs for U.S. businesses to $1.2 trillion, and hundreds of billions of dollars for costs for diabetes. And so really, COVID represents a fast pandemic on top of a slow pandemic of obesity, diabetes, and other diet-related diseases. And that we haven't paid enough attention to that slow pandemic, and this fast pandemic is now sweeping through our country. These are just some other numbers to look at this. This is a paper that is right now submitted, looking at interlinkages between obesity, hypertension, and diabetes. It's actually surprising that there's not as much direct overlap as you might expect. There are people who just have hypertension, just have obesity, and so on. But if you put the three together, 60% of adults have either obesity, hypertension, or diabetes. And if you add waist circumference and blood cholesterol, 88% of adults have abnormal metabolic health. Only 12% of US adults are metabolically healthy. And this is creating tremendous disparities among Black Americans, Brown Americans, low income and Americans of all ethnic races and ethnicities. And this is one paper that we published just a few years ago, linking NHANES to the mortality file, so following people. And we looked at risk of all-cause mortality, cardiometabolic mortality, and subtypes according to SNAP participation and eligibility. And so Black is the reference, is the SNAP ineligible individuals who have, above the poverty level, a little bit higher for SNAP eligibility of income. Blue, interestingly, is people who are SNAP eligible by income but don't participate in SNAP because they have other social networks or other support groups, even though they have low income. And then red is SNAP participants. And you can see adjusted for all other risk factors, these are multivariable adjusted, SNAP participants have a twofold higher risk of all-cause mortality than SNAP ineligible, and in SNAP eligible non-participants have 50% higher risk. And this is largely driven by cardiometabolic health, in particular diabetes. A threefold higher risk of dying from diabetes if you're on SNAP than if you're not on SNAP, adjusting for other factors. This directly links to COVID-19. As I said, it's a fast pandemic on a slow pandemic. This is one analysis from New York City. There have been many of these. Multivariable adjusted, if you have obesity, a fourfold higher risk of hospitalization, severe obesity, sixfold higher risk, diabetes, a threefold higher risk, heart failure, a fourfold higher risk. And actually, I should have updated this. This was from the preprint. The updated report, these are a little bit smaller, hypertension a little bit higher. They're about threefold higher risk each. And so I apologize for not updating these. These are from the preprint, not the final paper. But on average, about threefold higher risk for each of these conditions put together. And this has been seen in every country that's looked, in every region that's looked around the world. Mexico should be added to this list, just reported the same thing. And a CDC report using the best available national data just came out last month, showed that if you're a 35-year-old adult in the United States with any chronic condition, obesity, diabetes, hypertension, cancer, or chronic lung disease, just any one of those, you have the risk of hospitalization of a 75-year-old with none of those conditions, and the risk of death of a 65-year-old with none of those conditions. Now, these conditions always cause what we call biologic aging, where you sort of have disease rates at higher risk for your age. But this 30 to 40 year risk of biologic aging is almost unheard of, and is really just shows how linked COVID is to these factors. The mechanisms are unclear. We really need major efforts on science to understand why these mostly diet-related diseases are so strongly linked to COVID. Reduced immune function is possible, higher systemic inflammation is possible. One really interesting additional possibility is vascular endothelial dysfunction, which is a common underlying factor in all of these conditions. COVID-19 is quite unique among respiratory viruses, or if not unique, very unusual in that it not only infects the pulmonary epithelial cells of the lung, but it also affects vascular endothelial cells. And this was just reported about a month ago. And this likely causes the acute kidney injury, which is very prominent. A third of hospitalized patients and 90% of ventilated patients get severe kidney damage. the stroke, the vasculitis in children, COVID toe, all of this is due to probably the vascular endothelial effects. Of course, these comorbidities are all linked to poor quality diets and physical inactivity, which themselves hurt the immune system, and obesity can hurt pulmonary function as well. And we've done a paper, Megan O'Hearn, a doctoral student at the Friedman School, has led this paper. It's now been submitted, simulation modeling, what percentage of U.S. hospitalizations could have been prevented if we did not have the severe poor cardiometabolic health that we had. And what we found is that about 30% of all hospitalizations are attributable to obesity, about 21% to diabetes, about 26% to hypertension, and about 12% to heart failure. And when you model them jointly, we model that 64% of hospitalizations in this country would have been prevented if we didn't have these conditions in our country. And just imagine the difference if we had only 1/3 the rate of hospitalizations and death, how much less suffering there would have been, how much less economic damage there would have been. And when we look by age and by race at these different factors, this is hypertension. I just want to highlight a couple of things. Looking at young or middle-aged whites and blacks, you can see that this explains at least some of the significant disparities that we see by black race. Blacks have about a 40% more attributable hospitalization risk due to hypertension alone. And then if this is obesity, it's not as large, but about a 20%, 15% higher risk, attributable risk due to obesity than whites. And so this also partially explains the disparities. Now, how can we address this? Well, we've had a multi-year, multi-grant modeling project called foodprice.org. You can look on called Food Price. You can look on our website for our many papers. This has been supported by now 4 National Institutes of Health R01 grants with myself and several other faculty. And we've tried to understand and model the best buys for an enabling environment to help reduce these risks. And can't go through all of them. Obviously, I'm just going to quickly go through some of these just for the Q&A later. Let's talk about economic incentives. That's clearly something that's important. This is a modeling paper we just published a few weeks ago on different types of sugar-sweetened beverage excise taxes. What if the United States passed a national volume tax, a tiered tax, or an absolute sugar content tax? This is the cost effectiveness plane, which shows the incremental costs, net cost of the intervention, and the intervention incremental quality adjusted life years or health gains. Usually when you're doing cost effectiveness analysis, you're up here. You're almost every medical intervention, you're paying per dollar. So this is where you want to be. You want the intervention to cost money, but be effective. So you spend money to gain health. Almost all cost effective analyses are here in this plane. You obviously don't want to be here. Here, the intervention is less effective and causing harm. What we found is any type of sugar-sweetened beverage tax is what's called dominant. It saves money and saves health. So there's no reason, not to do this from an economic perspective. And what's interesting is when we compared, this is the 1,000 simulations and the 95% confidence intervals. When we compared the 3 types of taxes, a volume tax, which is actually what's been passed in the United States, has only been volume taxes, taxes per ounce, versus a tiered tax or a tax on absolute sugar content, we found bigger health gains and more savings for the tiered tax and the absolute sugar content tax, because those also stimulate industry reformulation. If you just tax volume per ounce, then industry has no incentive to lower the sugar per ounce because the tax is per ounce. But if you do a tiered tax or a tax per sugar content, then industry has additional incentives to reformulate, and you see significant benefits. And so over a lifetime of current Americans, we found that if there was a national SSB sugar tax passed and on absolute sugar content, a penny per teaspoon, which is about a 10% tax on average, that we would see 1.85 million fewer cardiovascular events, 0.55 million fewer diabetes cases. The net cost to government and industry would be about $3 billion. So government and industry together would pay about $3 billion for this. The tax revenue would be $42 billion, and the healthcare savings would be $107 billion. So this is just a best buy for our nation. And what about SNAP, using economic incentives in SNAP? There's been the GusNet program, which has introduced 30% subsidies for fruits and vegetables, but at a very, very small dollar amount. And so this funds roughly $1 per person per year of incentives. So very, very low amounts, but it's positive, but not enough. People have also talked about adding SSB restriction, and then you could also do a combination of subsidizing and disincentivizing, but not restricting types of foods in SNAP. And so what did we find when we modeled these different interventions nationally, if you extended this to everybody on SNAP? We found that if you actually extended the fruit and vegetable incentive to all people on SNAP for all their fruits and vegetables, it would cost about $6 billion per year. So it's fairly expensive. You'd prevent 300,000 lifetime events. And at 5 years, this wouldn't be cost effective. It would cost $550,000 per life year saved. But by a lifetime, it would be cost effective at $66,000 per life year saved. If you add sugar, sweet, and beverage restriction, you would more than double the benefits, and you would substantially reduce the cost per life year because you're getting many additional life years saved. And so if you restricted sugar, sweet, and beverages, it's almost cost effective at 5 years and highly cost effective at a lifetime. But, you know, sugar, sweet, and beverage restriction in SNAP is extremely ethically and morally controversial. You know, why should low-income Americans on SNAP not be able to buy sugar, sweet, and beverages? And so an alternative is to disincentivize sugar, sweet, and beverages and junk food and use those disincentives to pay for healthy food. So everybody has choice, but you get slightly more or less benefits depending on what is purchased. That incentive-disincentive program we found would prevent almost 1 million lifetime events of the best benefit, and importantly, be immediately cost savings for the government with $10 billion savings at 5 years and $63 billion in lifetime savings. So SNAP Plus, an incentive-disincentive program, we think is also just an obvious choice that we should, because it preserves choice and it provides nudges, economic nudges toward healthier eating and saves money. There are many, many other financial rewards that can be tackled, this includes financial rewards for businesses, tax policy, using healthcare, life insurance, and nutrition assistance dollars, changing ESG, what environment, social governance criteria for investing, catalyzing entrepreneurship, B corporations. We're doing a lot of work in this area and happy to discuss that in the Q&A. And I do think business innovation and disruption with incentives for business is really important. We're working on this through the Tufts Food and Nutrition Innovation Council. The American Cancer Society is a member of this and are helping us work with businesses to try to see how they can be incentivized to create healthier, equitable, and sustainable foods. Don't have time to go through all of the other environments, enabling environment policies, research and innovation, healthcare systems, schools, work sites, standards and labeling are all important. I'll just show you some of the slides again for the Q&A. Medically tailored meals, very, very important to introduce. Produce prescription programs, extremely promising for letting healthcare pay for healthy food. We've done simulation modeling of this, and we find if you gave produce prescriptions to everybody in Medicare and Medicaid, not just high-risk people, but every person in Medicare and Medicaid could buy discounted fruits and vegetables, that this is cost-effective, and it costs about the same as statin drugs for primary prevention at 10 years in terms of its cost-effectiveness. So this is something, if our health insurance pays for statins, it should certainly pay for fruits and vegetables. And this is happening in real time. The Farm Bill, the state of California, major health organizations like Kaiser, insurance companies like John Hancock, and newly introduced bills in Massachusetts and federally. And I want to draw attention specifically to this bill, which was just introduced about a month ago. This is a landmark bill. Everybody should call their elected representative and tell them that they support this bill. Medically tailored home delivered meals in Medicare. This would instruct Medicare to actually test paying for food and evaluate it, and that would be just a landmark action. And I'm just going to end with research and innovation. There's a lot of research that needs to be done, and we have a white paper that was just published on Monday in the American Journal of Clinical Nutrition. This talks about key options to strengthen research. We have to have stronger research to accelerate discoveries. There's cross-governmental approaches, there's within NIH approaches, there's within USDA approaches. As just one example, within NIH, it's time for a National Institute of Nutrition to be complementary to all the great existing work that's going on in NIH. We have an incredible coalition of 75 plus organizations standing in support of strengthening federal nutrition research, including the American Cancer Society and the American Cancer Society Cancer Action Network. If any organization listening wants to learn more about this, please contact me. And so I think it's time to fix food through economic incentives, through food as medicine, through research, innovation, and entrepreneurship. And we really need to take this on like we took on going to the moon. We can fix this. We can leverage food as medicine, incentivize and shift to real food, and build a strong public health and food infrastructure to help with disparities, health, and healthcare spending. So thank you very much, and I look forward to further discussion.
Thank you so much, Dari. Some sobering statistics that really, I think, really helps to make the case for why creating healthier food and beverage environments now is critical and not something that to be put on the back burner as we deal with kind of the acute crisis that is COVID-19. So I'm going to turn it over to Julie Ralston Aoki to talk a little bit about how health systems can think about making some changes through policy to change their food and beverage environments in their facilities. Julie?
Thank you, Kristen, and thank you, Dr. Mazafarian. I'm just going to share my screen here. All right, I want to start off by just sharing with you a little bit about the Public Health Law Center and who we are and what we do. We are located in St. Paul, Minnesota at the Mitchell-Hamlin School of Law, which is located in the Bdote region of the traditional homelands of the Dakota people. We are a team of attorneys and policy analysts who work nationwide on public health policies to prevent and reduce chronic diseases and promote health equity. Our mission is to help communities develop policies and laws that will be grounded in community, evidence, and solid legal principles. We work mainly in the areas of commercial tobacco control, healthy eating, and physical activity policy with a generalist approach to public health policy. As a nonprofit organization and with support from our funders, the center provides legal technical assistance in the core areas we work in. Our legal technical assistance includes research, publications, in-person trainings, and webinars on a wide range of topics, just like this one, related to public health. We assist communities with policy development, and we can review tribal, state, and local policies and provide sample language to help communities achieve their public health goals. But we do have some limits on our work. We do not provide direct legal representation, and we do not lobby. The work we do at the center is done with the goal of advancing equity. And what that means to us is that we are committed to partnering with communities and organizations to help them use the power of law in a way that addresses the social determinants of health and meets the specific needs of all the community members, but especially those who unfairly bear a greater burden of health inequities and other social harms. We do not believe that equity is achievable through a one-size-fits-all approach. And I would like to begin my portion of this webinar by acknowledging the crisis that we are in our communities right now, and say that the Public Health Law Center joins the protesters here in Minnesota and across the world in calling for justice for George Floyd, Breonna Taylor, Ahmaud Arbery, and the many other Black people who have been murdered by law enforcement in the United States. Racism is a public health crisis that demands sweeping policy and systems changes, and we renew our commitment to uprooting white supremacy and breaking down structural and systemic racism through our work as public health advocates. Now, along with the rest of the world, of course, hospitals are dealing with a lot right now. We know that. So maybe you're asking yourself, why are we even talking about sugary drinks at this time? Well, Dr. Mazafarian talked about the links between nutrition-related chronic disease, COVID-19, and equitable health outcomes. And this graph is just one example of those results. It's from the APM Research Lab, which is tracking racial disparities in COVID-19 outcomes. And what it shows us is that when you look at the age-adjusted mortality rates from COVID for all Black, Indigenous, and people of color, they are at least or almost 2 times the rate for white people, with the rates for Black and Indigenous people being nearly 4 times higher than the rate for white people, with Black people showing the greatest inequity. This is just another way of saying what Dr. Mazafarian just so eloquently walked us through. But what this data tells me is that the work that you and I and all of us were doing pre-COVID to address the inequitable impacts of diet-related chronic diseases continues to be just as important as Kristen referenced. Because this is what happens when we continue to let people fall through the cracks and we don't use every tool we have to try to reduce and prevent these chronic diseases. Sugary drinks are a big contributor to these health inequities, and that's why it's important to keep up this work. Now, hospitals have been taking steps to cut back or remove sugary drinks from their facilities for several years now. And Dr. Mazafarian also talked about other policy or systems approaches that hospitals or healthcare settings can take. I'm going to focus specifically on this one because the movement in this direction has been really taking off. It started about 7 years ago or so, to my knowledge, and has continued to accelerate. So what I'm seeing over time, that what used to be considered a kind of controversial, sort of fringy move has become recommended best practices. As many of you probably know or have heard, in March of 2019, the American Heart Association and the American Academy of Pediatrics issued joint recommendations for policy level change related to sugary drinks to protect the health of children and adolescents. And those 6 policy recommendations are listed here on the slide. They made the 6 recommendations that are ranging from calling for excise taxes on sugary drinks, which Dr. Mazafarian talked about the effectiveness of those, as well as to calling on hospitals to model the change needed and implement their own sugary drink reduction policies. These recommendations build off of a 2017 American Medical Association resolution that encourages hospitals and medical facilities to offer healthier beverages such as water, unflavored milk, coffee, and unsweetened tea for purchase in place of sugar-sweetened beverages. Now, ACS has been working to support hospitals in these efforts. In 2018, it conducted key informant interviews with some hospitals that have eliminated sugary drinks or taken steps to reduce the availability of these drinks or encourage healthier choices. Now, the Public Health Law Center didn't work on this part of the project with them, but Kristen has given me permission to share some of this information from those interviews on this webinar, and also she contributed some of the slides, so thank you for that, Kristen. Now, the objectives of these interviews was to explore the needs and challenges that hospitals face in adopting a policy to reduce sugary drinks. ACS staff talked with representatives from 11 hospitals, 5 with policies to completely eliminate sugary drinks, and 6 that took steps to reduce consumption. They asked the hospitals why they were making these changes, and 2 key themes emerged. One is that hospitals felt a desire and even an ethical obligation to model the healthy eating behaviors that they were recommending to their patients. And as noted on the slide, children's hospitals especially felt they needed to lead by example. Another motivational theme was that hospitals wanted to do a better job at supporting the health and wellness of their employees. Implicit in these motivations is a recognition that sugary drinks are a contributor to poor health. As Dr. Mazafarian explained, sugary drinks are linked to a higher risk of a host of chronic diseases and other negative health impacts. And I've listed some of the diseases that are associated with sugary drink consumption here. And as you can see, many of these are all in the leading causes of death in the United States. For example, sugary drink consumption is linked to a 30% higher risk of developing type 2 diabetes. And people who consume sugary drinks often have a 46% increased risk of metabolic syndrome. Consuming at least 1 sugary drink a day increases risk of hypertension by 12%, and consuming at least 2 sugary drinks a day has a 22% increased risk of cerebral infarction or stroke, and so on. This list illustrates just how cynical this Pepsi ad slogan of "Live for Now" is. And of course, a big part of this dynamic is that we see racial and ethnic disparities in all of these health and chronic disease areas when comparing rates for white people and Black, Indigenous, and people of color. For example, I want to especially call out oral health, because the CDC reports that non-Hispanic Blacks, Hispanics, and American Indians and Alaska Natives generally have the poorest oral health of any racial or ethnic groups in the United States. And there are clear links between sugary drink consumption and that. Similarly, we see significant equities in diabetes rates based on race. Again, Dr. Mazafarian touched on this, but I think it's worth reiterating. We see that Black, Indigenous, and people of color show rates that are roughly 1.5 to more than 2 times as high compared to white people. And I want to also note that there is wide variation in this prevalence for groups of people depending on where they are, or for Indigenous communities depending on their tribes. For example, for Alaska Natives, the diabetes rate is 6%, but for Indigenous people in southern Arizona, it's 24.1%. The same is true for across different Latinx or Hispanic groups. For example, Central South Americans have a rate of about 8.5%, while Puerto Ricans have a rate of 14.8%. And this is likely also to be true for Asian groups as well, depending on their ethnicity and immigration status. These racial inequities are not accidental or just an unhappy genetic coincidence. They are the product of systemic racism and a confluence of negative social determinants of health that cause Black, Indigenous, and people of color to have shorter, harder lives than white people. There's a lot that I could say about this, but I only have about 10 more minutes, so I want to keep the focus on sugary drinks and the changemaker roles that hospitals have here. But one aspect of this systemic racism that I think it's important to highlight is the way that soda and junk food industries prey upon Black, Indigenous, and people of color, and particularly youth. The Yukon Rudd Center on Food Policy and Obesity does an annual report on racially targeted junk food marketing and sugary drink marketing. Their latest research report found that African American youth are 3 times as likely to see TV ads for sports drinks and more than twice as likely to see ads for regular soda and energy drinks compared to white youth. They also found that 8 out of 10 ads seen by Latinx kids on Spanish language TV promote fast food, candy, sugary drinks, and snacks. And it's not just TV ads. For example, research on outdoor advertising has found that similar to what we've seen with commercial tobacco advertising, lower income African American and Latinx neighborhoods have more outdoor ads for sugary drinks compared to higher income neighborhoods. Studies have also documented the effective use of celebrity endorsements by sugary drink industries, particularly by athletes and entertainments of color. Now, food and beverage companies may explain that they target Black and Latinx children because these companies consider them to be cultural leaders, that other kids will follow what they do. And maybe that would be okay if the foods were healthy, but they're not. Instead, youth of color are seen as a growth market for sugary beverages and other unhealthy foods. And this has led to the disparities in sugary drink consumption rates, so that we see Black children consuming 3 times as many sugary drinks compared to white children, and 74% of Latinx children having consumed a sugary drink by the time they were 2 years old, compared to 45% of white children. As well as we see significantly higher consumption rates for American Indian and Alaska Native peoples. Again, the disparity will depend on the region and the tribe. And of course, it's not just racial inequities. We are seeing other kinds of socioeconomic inequities in this area because sugary drink intake is also higher for adults with less education, adult smokers, adults with a disability, lower income households, and in certain US regions, and particularly the Northeast and the South. What all of these population groups have in common, of course, is that they also all have disproportionately high rates of nutrition-related chronic disease. So the bottom line is that sugary drinks are a real and serious health equity issue, and we need to address them accordingly. Now, I'm pretty sure that you wouldn't be taking time out of your busy day to join this webinar if you didn't already think that this work is important. But hopefully I've given you some additional talking points for making the case and for amplifying the importance of this work from a health equity perspective during these especially challenging times. So we've talked about the why of this work, but now I want to get into the how and how hospitals are approaching it. So the hospital key informant interviews that ACS did had some good takeaways on this point. The interviews showed that several factors were very helpful in making hospital healthy beverage initiatives successful. These factors included using tools, having a champion at a high or leadership level, being able to draw on literature and evidence base to back decisions and actions, having examples from other peer institutions to draw on and highlight, and being firm with vendors about their commitment to making this kind of policy change. The hospital's interview for the ACS project also identified these 5 key challenges to moving sugary drink policy initiatives forward. Fears about loss of food service or vending revenues if sugary drinks are reduced or removed, that employees will be unhappy about the change, that some hospitals were concerned that they'd get dinged in their patient satisfaction surveys. Some also had concerns about arguments that the hospital was inappropriately infringing on people's individual choices. And a few hospitals were wanting to see, to make sure that this kind of initiative aligned with what their competitors were doing. And these are all the same kinds of concerns and challenges that I've heard in the years where I've been working with hospitals on this work. So in response to these kinds of concerns, we had developed a toolkit to address these points and to help hospitals who are doing this work to do it successfully. And the Public Health Law Center and ACS partnered to update this toolkit, which is designed to help organizations create healthier food environments with a special focus on hospitals and healthcare settings. And so the toolkit focuses on beverages, but many of the principles and approaches can be applied to other types of food environments, as well as to other types of organizations. And I just want to say that the toolkit was originally adapted from a guide that was created by the Boston Public Health Commission in partnership with Healthcare Without Harm, who was an early and valued partner to the Public Health Law Center in this work, along with the Institute for a Sustainable Future, the Minnesota Cancer Alliance, the Minnesota Department of Health Comp Cancer Program, and Blue Cross and Blue Shield of Minnesota. So you can see this is a work that has been supported by many partners. And my colleague, Craig Massetti, and I are working with ACS to provide some technical assistance to some hospitals who are pursuing policies in this area. Yes, even in these pandemic times, using this toolkit. And just one thing I wanted to say about this pandemic situation that we are in, you know, we're seeing that in a way, in sort of odd, a silver lining kind of way, that these kinds of very disruptive times can actually create opportunities for change. So just as in some hospitals have leveraged, you know, cafeteria renovation efforts or vendor contract turnover periods as a way to sort of have a fresh start and roll out a new initiative or policy to reduce or eliminate sugary drinks, we are seeing that, like, for example, tribal casinos, many tribal casinos are taking this opportunity as they reopen to implement smoke-free policies. And in the same way, hospitals who have shuttered or reduced their cafeteria or food service operations can take this as an opportunity to perhaps roll out a policy like this. But I want to talk a little bit about the toolkit. So the building blocks for success, which is featured here on this screen, is the foundation of the toolkit and is a guide that talks about the various stages of a healthy beverage policy initiative. And it's designed so that whatever stage an organization is in, they can plug in and use the toolkit. So we've laid out the stages in sort of an order, but it doesn't have to necessarily go in this order. But what the stages include: creating a team or work group that will be designing and implementing the initiative, assessing the food and beverage environment so that you know where you're starting from and what you're dealing with in your environment. This also includes assessing staff perspectives and readiness. Then we have a section about developing the elements of a beverage policy or initiative and what are the key considerations to think about. For example, will you aim to eliminate sales and services, or will you just reduce them? And how will you do that? And what other types of policy components will be important or helpful to include, such as pricing or placement strategies? How will you integrate educational efforts and healthy beverage promotion efforts into your initiative? We also have a section about best practices for putting policies in writing. And then we have sections on strategies for engaging and building buy-in with management, leadership, staff, and visitors, as well as guidance on how to roll out and implement these policies, including dealing with vendors, and pointers on addressing and overcoming challenges, tracking and evaluating progress, and finally, a reminder about celebrating successes. Each section of the guide includes practical tips and links to additional tools to help with the work. Here are a couple of examples of what some of those features look like. So it's just talking points to use with vendors when you're rolling out a policy, and tools for educating and engaging staff and leadership. The toolkit also includes supplemental fact sheets and mini guides that focus on specific topics. Many of these are the specific topics that were raised, that typically come up as challenges or concerns or barriers to these kinds of policies. So this first piece, Sickly Sweet, talks about why focusing on sugary drinks is important and necessary for addressing chronic disease and health inequity. I'm happy to say that since we first created this piece, we are actually finding we have to do less of that kind of case making as people now more and more are really getting it. The second piece, Healthcare Can Lead the Way, lays out the rationale and provides some data to help build buy-in across hospital leadership and explain why hospitals are important leaders in this work. For both of these pieces, Sickly Sweet and Healthcare Can Lead the Way, we have state-specific versions on the website for the following 7 states: Illinois, Minnesota, Missouri, New Jersey, New York, North Carolina, West Virginia. So if you're in one of those states, I encourage you to look at those. The next piece, Healthy Beverage Hotspots, helps readers understand the varying considerations related to what kinds of food outlets or venues may be on campus, what are the contract situations there, and how to navigate that. The Healthy Beverage Policy piece provides guidance on how to define key terms such as what is a healthy beverage, if that's the term the policy will use, and provides examples of recommended beverage standards from different health expert groups. We also have this piece called Healthy Beverage Policies, Healthy Bottom Lines, which, as the title suggests, addresses the common questions and concerns that almost always come up about potential revenue impacts from these types of initiatives. And then we have a piece to address the concern about what are my competitors doing. We have a document called Food and Beverage Pledges and Policies that identifies all the national, regional, state, and local healthy hospital initiatives that we could find public information about, and also identifies hospitals that have adopted healthy beverage policies or pledges. Then the artificial sweeteners piece addresses the common questions and considerations that come up relating to artificially sweetened beverages and whether and how they might be included in a beverage initiative. And finally, the frequently asked questions document is designed to be a handout that lays out the responses to questions that typically come up in response to these kinds of initiatives. So that wraps up my portion of the webinar today. I hope that you'll please take a look at these tools on our website, and I hope that you'll find them useful. If you have any questions about the toolkit or about the work that we do, I'd be happy to answer them in the Q&A. And with that, I will turn it back over to Kristen.
Great, thank you so much, Julie and Dari, for these great presentations. Before we get into the Q&A, I just want to give a little bit of a shout out to remind people that this is the first of a series that we're going to be doing on this topic. The next webinar is scheduled for August 26th at 2 p.m. Eastern, 1 p.m. Central Time. And we're going to hear specifically from University of California, San Francisco, which was one of the systems that was an early adopter of completely eliminating sugary drinks in their facilities, and did a really rigorous evaluation, including looking at the health impacts on their employees of the policy. So we will be dedicating that webinar to hearing about their experience of implementing that policy and evaluating it. So we're really excited about that. And then the next series will be roughly monthly after that, and we will be digging into some more kind of case studies of hospitals and health systems that have taken on this challenge and their experiences with that. Okay, great. So let me just start with a few questions that we've gotten. One, and both of you kind of touched on the idea of policy change within a health system, but also larger public policy, specifically sugar sweetened beverage taxes or SNAP incentives. So a question we had was, how can health systems become more engaged and effective advocates for those types of public policies? So essentially, how do they get beyond their four walls to really become advocates, kind of similar to how in the tobacco control movement, health systems started by eliminating tobacco use within their systems, but then became advocates for other public policy that were incredibly effective in reducing tobacco control.
Should I take a run at that one? So I think you, Kristen, you kind of provided a great example from the tobacco control world. I mean, their clinicians, doctors, hospitals played a very important role. Clinicians can be very powerful spokespeople to policymakers about the importance and the need for these initiatives. And, you know, and I have seen too, even within, you know, when I first started this work, I had naively thought that it would be a really soft sell with hospitals, not sort of understanding, you know, that they're dealing with all the same challenges that we are dealing with out in the world. And I saw there that within those institutions too, clinicians are super powerful. So bringing those voices out to the public, talking about it, raising awareness is a crucial, important role. And being primed and ready to talk with policymakers and other thought leaders in a community about the need for this, providing the data, all of those things are key roles.
Yeah, I can add to that. I think, you know, hospitals first, they're usually, you know, one of the major employers. And so actually a lot of staff and people are there. They're mirroring positive or negative behaviors for all the patients and families and staff that come in, whether it's the, you know, the nurses or other allied providers or the doctors when they see what's there and what they're doing. They have large procurement power, right? They're buying a lot, and so that is very influential. And they're also very influential, you know, businesses, even if they're nonprofits, they're generating revenue for the economy. So they're very influential in sort of the chambers of commerce and with elected leaders. And so I think that you know, it's very, very important. And linked to these things, I think, are two really important facts. So one, I think that Julie talked about this, about the systemic racism, and I think there's a movement now which I support and agree with, that when we say health inequities and health disparities, if there's disparities by race, ethnicity, there's systemic racism. That's the definition of systemic racism. There's systems problems that are causing racial disparities. And so I think as a research and clinical and advocacy community, we need to start maybe shifting and saying, instead of, I haven't said it, you know, there are disparities by race, there's systemic racism. And so, you know, all of this is a sign of systemic racism, and hospitals should be in the lead to talk about that and overcome that. And then lastly, this is a little bit tangential, but I'm sure it'll come up, is another really important thing, which includes to do these policy and systems changes, is medical education for doctors and clinicians on these things. And it's not that doctors don't want to learn about these facts. There's been many studies in the last few years showing that medical students, residents, fellows, practicing physicians, 80–90% want to learn more about nutrition for their patients, and 80–90% say they did not learn enough in their training. And so there's a huge mismatch. And there's been, you know, individual medical schools which have tried to do things one-on-one, but I think of those as sort of Band-Aid fixes, little fixes here and there. There's a very simple way to address that, and that will both make clinicians advocates for their patients and advocates for their communities, is to change the tests. All we have to do is change the test, change the USMLE, the licensing exam that all MDs have to take, change the board exams for all, you know, board qualifying physicians, change the continuing medical education requirements that each state has for active physicians. If we just make all of those exams and requirements have 5–10% questions on food and lifestyle, we change education in every program overnight, because they teach to the test. You have to pass the test. And so there is actually some movement toward that, and the American Board of Internal Medicine is thinking about that. And so that's something that, again, is very important and very straightforward to do.
Yeah. Great, thank you. So another question we had is, can you guys talk a little bit about the limitations of just promoting healthy options? So this came up a lot in those interviews we did with health systems, in which, you know, there was some feeling that, well, we can just offer everything and people can have the choice, and we can educate people about making healthier choices. Why is it important to not only offer healthy options, but to also include strategies to kind of restrict or remove or disincentivize some of the unhealthy options?
I can take that. to start. So I think, the implicit in your question is first that, there's sort of an interest in incentivizing there's interest in incentivizing, trying to put out the healthy options and not put out the, not restrict the unhealthy options. But one important point, Kristen, is that the opposite is also true. There's a lot of public health and policy interest in restricting and putting front of pack labels and, like in Chile, black labels on the unhealthy products without any attention on getting the healthy products in there. So I feel like there's these two separate camps of interventions. Right. One intervention is like, let's focus on calories, let's focus on salt, let's focus on sugar, without any thought about, well, how are we going to actually get fruits and vegetables and nuts and beans and whole grains into the food supply? And then, as you said, there's kind of in the procurement side, well, let's just give people choice and make sure people have choice. And as long as they have choice, that's what matters. And so I think both are flawed, right? And so you need to both incentivize and encourage the good and disincentivize the bad. And some things, need to be, and so I think just providing choice by itself is not sufficient, right? There needs to be incentives, economic incentives, other incentives for the good, and there needs to be disincentives for the bad, and they can be economic or other. So I do think both are important, but I just want to say, as a public health community, I've also I worry, especially with a lot of international policy, that we're taking just the tobacco playbook, which is tax, warning labels, marketing restrictions for children, and access restrictions. And that works very well for additives, sodium, added sugar. That works very well for products that have really no intrinsic need to be in the food supply, like soda. That tobacco playbook works. But to, again, encourage the healthy foods that we really need, the beans, fruits, vegetables, nuts, seeds, plant oil, seafood, yogurt, there's a whole bunch of healthy foods. That's only going to happen if we start paying for them. And that's why I think these fruit and vegetable prescriptions, medically tailored meals, using healthcare dollars to pay for food. We spend a fifth of our economy on healthcare. We should spend some of that on food. Using SNAP to encourage healthy eating. I think both are really important.
Yeah.
Can I just add that I agree with what Dr. Mazafarian said, but it really has to be a both and approach. And that there's even, the research that has looked at these different interventions, like in cafeterias, has found that it's when you just do the positive, like do educational stuff and try to increase choices, that helps a little bit, but you don't really change consumption patterns or purchase patterns until you start taking things away or making the unhealthy things more expensive or harder to get. And so you need both of those approaches. And I would also just say, I talked a lot about the influence of marketing, and I think nobody, I think people in the United States, adults, highly educated people too, but on this webinar, we don't like to think that we are susceptible to marketing influence, that we are smarter than that. But study after study shows that that is not true. Mm-hmm. Marketing works. And so when you have 50 to 60 years of marketing of Oreos and Cheetos and Twinkies and things like that, trying to compete, a carrot or leafy greens, competing with that, where we haven't had the same kind of push or expenditure or focus on marketing those types of foods, you're just setting up it's a very uneven playing field there, and that that has to be taken into consideration.
Yeah, I'll say, as the parent of a teen and preteen, I am acutely aware of how marketing influences my own ability to influence what my children eat. So that's for sure. There was a question, and I think this was related to the part of Dari's presentation where he was talking about modeling different SNAP incentives and also sugar sweetened beverage taxes. Do you feel like there's greater political will at the federal level to address some of these things via SNAP incentives or SNAP changes versus taxes?
Well, there are people in Congress, particularly in the House, who have both proposed soda taxes. So Congresswoman Rosa DeLauro, the SWEET Act, has proposed soda taxes. And there are people who have proposed, sweeping increases to SNAP incentives at the federal level. So I think there is interest in that, but there's not enough people that are interested in that. And so I think at the federal level, what has been missing is linking these things back to the federal budget. I really think that dollars drives decisions in the government, dollars drives decisions for businesses, dollars drives decisions for families. And there are other things that drive decisions, but dollars are at near the top. And so I think that, if we go and advocate for more SNAP incentives because of moral or ethical or systemic racism arguments, you're not going to get more than 10% of Congress to vote that way, right? Even though they might say they care. But if you start to show that it's an investment, that like SNAP Plus, that investment, that incentive disincentive program I showed, can save the federal government $60 billion in healthcare spending over a lifetime of current SNAP recipients and make people healthier, then they start to sit up and say, really? That's a lot of money. And so I think that, shifting the conversation from that this is the right thing to do, which many of us believe in our hearts it should be sufficient, to this is the economically right thing to do, I think will help. At the local level, there's also been not a lot of uptake in SNAP incentives, and also a lot of challenges in any restrictions. And so SNAP restrictions to restrict soda have been supported by some. I think it's very controversial, and I'm personally very conflicted about that. But I'm not conflicted about telling people, look, if you buy soda, you'll get 70 cents on the dollar. That's your choice. But if you want to be in that program, you'll also get $1.30 if you buy nuts or whole grains or fruits and vegetables. And you can choose to be in SNAP Plus or choose to be in regular SNAP. It's up to you. You can pick which program you want to be in. I think a lot of people would choose the SNAP Plus, so they still can buy whatever they want, but have this. So I think that we have to shift from a pure health and moral and ethical arguments to dollar arguments. And then we do have a paper that we published. I'd have to look for this specific question, but I'll find it and send it to you, Kristen. You can share it with the e-list, where we did polling of local and state and national policymakers and advocates, and asked them which of these policies they thought were more feasible and impactful. And what's interesting about this, it's a survey, it's just people's opinions, but people generally felt taxes were not very feasible. So it's interesting, even though taxes raise revenue, and locales like Seattle that have passed them are raising huge amounts of money that they're then using to subsidize fruits and vegetables for low-income residents. Even though those localities have had a lot of success, there's still a resistance. There's still a perceived resistance to those kinds of policies.
Right. Okay, I think we have just time for one more question. And Julie, I think you've had some experience with this, so I'll give this to you first. Any tips or experiences on building coalitions around this topic? And I know you have worked with hospital coalitions in the past on some of this.
Yeah, so that's a great question, because that's really important. It's super, I think that was one of the critical learnings from the research, the reports, interviews you did, or ACS did, Kristen, was about the important that a multi-sector coalition was critical. Mm-hmm. and so it's really important to think very broadly and to think about all the departments, the layers that go into a hospital's operations, for example. And so everyone from the facilities staff to patient services to the food and nutrition folks, of course, as well as the folks in your C-suite, and the union. If you have a union staff, nurses, all of those folks are important to need to be part of some involvement in an effort. And it's like any kind of coalition building effort, you want to think about, not everybody is going to have the same role in a coalition. Some folks they may not be necessarily part of the coalition, but you still have to reach out to them and engage with them. Or there's folks that you're going to want to be part of your coalition who may even lead the coalition. So it's just important to be strategic and thoughtful about how you build that, to make sure that your coalition does touch a wide base, but then that you're also building in people who are going to be supportive and champions for the effort and help the effort to be successful. And that means also being open to changes, because when you have to be authentic about including people and their viewpoints, and that means listening to the concerns that they have and trying to figure out how to address them effectively, because that ultimately will make your effort more sustainable and effective. And I think those same kinds of principles, like if you're talking about a wider, I mean, there might be community groups too, to reach out to groups who are concerned about the hospital's role as an anchor institution in selling food. I mean, we've seen stories about where the McDonald's at a hospital was one of the key sources of food in a neighborhood, because that was one of the only places there was to go to get food quickly. So, so you need to think about, there could be community groups who also play a role to help with an inside-outside dynamic if you're a leadership, or you know, if you need help in sort of building buy-in.
Great, thank you. Well, we are right at the top of the hour. I want to thank Julie and Dari for your time and great discussion and presentations. And I just want to remind all participants to please take the survey at the end of the webinar as you close out. And we will be emailing a link to the recording and the playback, as well as some other materials, to everyone who is registered for the webinar today. And thanks so much for everyone's time. We hope to see you on August 26th.
Thank you.